Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo. I'm here with my most recently fired up but cooling down co-host, Dr. J. Calvert. Don't get him going, folks. Don't do it.
Up?
You were a little fired up on our last podcast. Yeah. So we're going to cool things down a little bit today. I feel like I'm like light rock, less talk with the folks right now with this voice I have happening. We have caller 10 calling in. He wants to tell his girlfriend how much he loves her.
That is so funny.
But no, today we are talking about bottomed out implants, not to be confused with big bottom girls.
No, these are bottomed out breast implants.
They do not make the world go round.
That's actually a separate podcast, is bottomed out butt implants.
Oh, yeah. That's
Those
a whole
are not cute. But
other story.
We're not going to talk about that. We're talking about bottomed out breast implants.
Breast implants. So what does that mean?
That was my chair, by the way.
In case anybody was wondering.
If you guys heard anything, it was a chair.
It was a chair, folks.
Right. Usually blame Frankie, but he's not here. So, so bottomed out breast implants. The reason it came up is, because I just did a revision recently. And they happen for a lot of reasons. Mostly, it's really like surgeon-induced. They just...
Well, I think I'm just going to stop you right there because I think there's two ways that implants can be bottomed out. And I think it's important to distinguish. The most awful one is if the IMF, the fold itself, has been damaged, either just age, time, gravity, weight loss,
right, or
surgeon-induced, the fold was over-released. And so that actual fold has descended and the implant has sort of gone with it. That's one version of a bottomed-out implant, also called a double bubble deformity sometimes. But then you can also have a totally intact IMF, but the skin of the lower pole stretches out.
Right. The IMF, the inframammary fold, which there's, by the way, a totally separate podcast about that.
Yes.
It is intact and where it started.
To be, yeah.
But then the lower pole skin get stretched out. Big implants, big problems. That'll be another podcast in the future. But you know.
And that usually happens from big implants, loose skin. So weight loss patients are very prone to this having this happen to them. And that's pretty much it. Weight loss, bad skin, big implants, either of the two in isolation or combined. You're going to see that lower pole where the implant's sitting, distributing most of its weight, stretching out in the skin for whatever reason, because the implant's too big or the skin's too crappy, can't hold it where it needs to be. So the lower pole stretches out, and as a result, the nipple starts to head north, and the rest of the skin and the breast start to head south.
The term for that is stargazer.
Stargazer.
Yes, they are. Look it up.
They are. They're looking at the sky.
Yeah, and that's not cute. But yeah, how to, typically what happens is the patient will identify that things don't look awesome. Right. They don't really understand why. Because remember, this comes down to plastic surgery works. People get plastic surgery, they're happy. They, if you have small breasts and then you get an augmentation with a breast implant and it looks, decent, you're happy because it worked. Yeah. So then the nuance, and that's what we talk a lot about on this podcast, is nuance about how to make it beautiful, how to make it excellent. And these operations are all flawed. The surgeons are flawed, the operations are flawed. There's flaws about all of it, but the goal is to get a surgeon that makes it work. And so when somebody comes in and they have that over-released fold, I remember as a resident many times where the attending surgeon would say, I think we need to release the fold.
Mm-hmm.
And
during a primary or a
during
revision,
a primary,
it was in place, it's sitting where it's supposed to be, it's happy.
Right.
And the surgeon says, I'm going to intentionally
release the fold. And there are times you need to do that.
There are times when you 100%.
Need to do that. Very, very small breasts. You want to put in a big implant. You have to make room for
tuberous breast.
Yeah, tuberous breast. So there's lots of reasons to do it. But there are a lot of times that we did it there. I was like, we really didn't need to do that. We could have just put some implants in here and it would look really nice. And I come to learn probably around 2001 or 2, very early in my practice. And yes, I have been in practice that long. I am from another time. I've come in a time machine to tell you this, that you should not do that.
And you should
if you
not
don't have to release the fold, do not. And that was a big learning experience for me. And it is why my primary breast dogs, they really do. They turn out so much nicer because I don't meddle.
Respect the fold.
I respect the fold. I don't meddle with what's already there in place. I work around it. I do things. And because of that, when somebody comes with a broken fold, with an over-released fold and a bottom-down implant, I know how to reconstruct it. However, it's not easy.
It is so not easy.
It's not easy.
Because the forces that created the problem are still there. Gravity's still there. The weight of the implant is still there. So it is tricky. So if the problem is, as you're referencing, a bottomed out IMF, the IMF has been over-released or it was never in a great position to start out with, which I see with weight loss patients and older patients. The quality of the fold kind of just disintegrates over time. And if there's no implant in there, it's not a big deal. Who cares? But if you try and put an implant into a naturally weak fold, you're going to see this problem as well. And what it looks like is you have an implant, and then somewhere along the bottom half of the implant, you have an indentation, which is where the old fold used to be. And then the rest of the implant sits below that at its new fold. So to fix that, it's a big deal.
Big deal.
I'll tell you how I do mine, but you tell me how you do yours. Maybe we do the same thing. What do you do?
It depends. That falls under a big it depends category. First of all, it depends on the size of the patient, the size of the implant, and why the fold is where it is. So if they're bottomed out, and I have to recreate the fold, and it's a double bubble, well, I know where the old fold is because you can see it.
You can actually see it. That's helpful.
So if you see that, that's great. You pop out the implant, and you start reinforcing the fold, and typically you use something like a Galaflex or some sort of, either and no financial interest on the Galaflex, but you can also use, any kind of alloplastic skin product,
right? A cadaver skin, yeah.
So something, and then for me, it's like a very, very strong suturing exercise. I put lots of stitches, and then reinforce it with something. That doesn't help if they still want 800cc implants.
That is true. You may have to talk them down and downsize.
You can't talk
a little bit. You can't talk them down. So then you just, you do the best you can, and you say a prayer to the IMF gods.
You do, and then you just say, and we may have to do this again. And if they want to keep their gigantic implants, then they have a pretty strong chance that it's, that they might need some tweaking. And I tell those people, 25% chance we're doing something again, and they get it. I said, if we drop down from 800 to 450, you're going to have a very high chance of success. And they go, 450?
No. What, are you crazy?
What's wrong with you? What am I going to do? How am I going to? No. And
so they'll take that chance.
Yeah. The other thing that I do that I think is also helpful in a failed IMF, especially if it was under the muscle, if it was a subpectoral implant, switch it out. Yeah, take the muscle action. Take the muscle action off of that. Because a lot of my patients are fitness models. Everyone knows I operate on a lot of the fitness models for their implants. It's like a niche specialty for me, and so they like to lift weights. Yeah, and it's not just that they do bench press, but they do everything. They do everything that you do with your upper body
involves contract
your
those
pec.
Pectoralis muscles. 100%. And every contraction is pushing those implants down.
So in more cases than not, I tend to get them out from under the pec because it's not going to work if they really push again and it pushes on my repair. How's that going to, are the stitches going to win over some, really strong, buff, model with 600 to 800cc implants?
Yeah, no, I agree. I take these repairs very seriously. I think I'll probably do something similar to you. I use a permanent suture. Some people don't, and that's a very niche discussion amongst plastic surgeons, not necessarily pertinent to the podcast. But there are absorbable sutures and permanent sutures. And a lot of people don't like to put permanent sutures in the breast for reasons they think maybe infection or bacteria seeding. I do them all the time. If I want my IMF to stay in place, I'm not going to mess around with the suture that's going to dissolve. So I take a nice honking Ethibond suture and I go right up to where I want that fold to be and then down to the chest wall. And if I can snag a piece of the rib periosteum, I do it. And that is a very secure stitch. So I'll do a couple layers of those. And then I'll put a layer of mesh. I usually use Galaflex as well as an additional layer of internal reinforcement. Then I do all the contraptions afterwards. I have them use a shoelace bra. I have them wear a compression bra. And I tell them they can't exercise for 6 weeks. I'm much stricter with my patients than you are. I'm kind of more of a meanie. So I don't let them even look at a weight sideways.
Yeah, you're pretty tough about that.
Because that's how these things are going to be successful.
It's true.
And even then, there's still going to be some recurrence. But I have had pretty good success with that regimen of really just throwing the kitchen sink at these repairs because I do not want to be back there again.
With the Ethibonds, do you run them or do you figure of 8 them? What do you do?
I do a figure of 8 interrupteds, and that's my like set position.
Right.
Then I'll put the implants in. I'll set them up, make sure I like where it's sitting, and then I'll do a running to a PDS over that just to sort of reinforce it. And I know that it's going to work and be successful when the patient comes back to me a week later and is like, it really hurts to breathe. I'm like, yes, because those sutures down to the periosteum, which is like kind of the lining of the rib, it can feel sometimes like a cracked rib. And if you've ever had a bruised rib, it takes a while for that bruising and swelling around the rib to go away. So they do feel it for 4 or 6 weeks sometimes. It's not awful. It's not anything that needs pain medication. But the rib is bruised and it's swollen. And that's when I know I got a good stitch. Because once you get that, it's pretty secure.
Yeah, they don't like those.
They don't like them, but I'm like,
Yeah.
You're welcome.
No, I mean, you got to do that. Yeah, it's part of the deal. You got to really, you got to close it down. If you don't close it down, it's, it's going to recur. And
it absolutely will recur.
Especially with the big implants. And that's my jam, Okay.
Big implants, big problems. So then what about the patients who have an intact fold, but that lower pole, usually this is in patients that have had a previous mastopexy. So unusual to see it in just a primary implant with a fold that's in good position. You're not going to see necessarily a lot of that stretching out of the lower pole too much. But usually it's someone that had a lift at the time of their implant placement. And all of the rest of the skin up top was removed, the nipple's sitting higher and is in good position. But then over time, the bottom part of the mastopexy lift starts to stretch out.
Those are a little bit trickier. Now, if they've had a mastopexy, it's simple. You reopen.
It's super simple. You just take out some extra skin. Because usually that's what it is. The skin is stretching out on the bottom because the implant's sitting against it. Very common in the weight loss patients. And I tell them, at the time of their consult, you will be back here probably in 2 or 3 years, and I'm going to take some more skin because the bottom part's going to stretch out. But that was a fairly straightforward revision. You just redo their incisions that are already been made, take out some more skin, close them up. You don't even have to go anywhere near the implant again.
That's true. And sometimes you do. Sometimes you got to, and typically when you're going back, patients recently like to go smaller a lot of times. Right now there's a trend towards smaller implants, which is a very happy trend for those of us that are trying to fix these bottomed out implants.
Except for those patients that want to keep their 800s.
Yeah, I have those too. I have them all shapes and sizes, and I'm happy to help. But yeah, you're right. These are really tricky cases. We always talk about the cost too. What are these operations
are cheap.
These are expensive.
These are expensive. So if you got your first implants placed and you didn't have a lift, and this was 10 years ago or 5 years ago, and
oh my God,
it take whatever that price was and triple it at least for this, because not only has time gone by and prices risen, but the complexity of these revisions is so much more than the first time around, and really trying to get it right. And then if you're adding in the cost of additional mesh or some kind of, internal reinforcement, that's an extra cost as well. So the price goes up concurrent with the complexity.
Yeah. I mean, they are not cheap.
And the recovery is going to be a little bit more involved than the first time around, because you really got to just sit and let yourself heal and recover. There may be a drain. There's all kinds of extra moving parts now to this surgery that may not have been there the first time. Or they maybe should have been there the first time and weren't.
Yeah. I mean, I had a patient come in recently and they said, well, tell me about what you need to do. And I said, you need a mastopexy. Like they had these bottomed out, googly-eyed implants. One of them was like up
That's
here.
a medical term, guys. Googly-eyed implants.
Everyone knows what that means.
Like, ooh.
I think they got that. So, and I'm talking to the patient, and I said, "Look, this is pretty complex. It's going to take me about 3 hours to do this operation." She said, 3 hours? She's like, huh. I'm like, what's it going to cost? And, I said, well, these are usually, X tens of thousands of dollars. And, I think hers was like $38,000 or something like that. Because it was like, there's mesh, new implants, and
Right.
mastopexy. Beverly Hills prices, people. And she goes, God, the last guy only spent 45 minutes and it only cost me $11,000 to do this. I was like,
and there you go.
are you listening to yourself? Like, it looks it. I didn't know what to say. I was just like, geez, that's kind of the problem, is that it does, you rush through things, you're in a hurry, there's that, how many, there are guys I know that, and gals that can do a lot of breast surgery in one day. They can really whip through it. I can't.
I can't. I actually just had this conversation today with a consult. I was like, there are people that can do this surgery in 45 minutes. I'm like, I actually don't know how to do that. This is going to take me, a couple of hours to do it right and make sure that I get the pocket I want and that I don't disrupt the fold and that I put reinforcing sutures in if I need to. It's not like a open it up and slam it in there kind of thing. And, I want to futz with it and make sure I get the right size,
Yeah, I mean, that's been I think that's kind of been like a myth of plastic surgery, is that breast surgery is easy. And it's not.
It's common, but I wouldn't say, and I would say any well-trained plastic surgeon can obviously do breast augmentation, but you want someone that's going to take their time and get it right.
The artistry of breast augmentation is so important. It is. I mean, making breasts look nice is not simple. It's a lot of analysis. It's a lot of time assessing the issues. It's a lot of figuring, where do you want, it's and so what do you want this to look like when we're done? These are the photos I brought you, and you look at them, you look at their photos. There's a lot of, and then building your plan to get there.
Yeah.
That's the artistry. That's what makes these work or not work. And it's not simple. And those of us that do these complex revisions, we kind of see what happens when you don't do it that way.
Oh, yeah. I do so many of these IMF repairs that it makes my primaries. I have huge respect for that IMF now.
Yeah.
Because I know what happens if I have to go back and revise it, and I don't want to have to do that. So huge respects. Big ups to the IMF.
Respect the IMF, people. That's what we're saying here. Well, that's cool. Yeah, I think anything else we need to nail on this one?
I think that was kind of what we wanted to talk about. When people say, oh, my implants are bottomed out, it can mean a couple different things, and whatever it means kind of has a bit of a different treatment plan. Just know that it's, it may be a lot, and just be prepared for that.
And I will add one other point, though, that the device selection in the bottomed out implant is key, because sometimes it was the wrong profile, it was too wide, or it was too narrow, or it was too whatever.
I just thought of something.
Yeah, shoot. You don't have to raise your hand. Go.
This is where I don't think I've done this on this podcast. This is where I'm going to rail against the anatomic teardrop-shaped implant, because I have seen this bottomed out shape so many times in those ugly, sorry, my apologies to anyone out there that has those implants. Sometimes they look okay. And maybe those are the ones I haven't seen because they haven't come to me.
No, the bad ones.
The bad ones come to me. Because what I see is, so this is back in the day, like 2014, 15, 16, we had these implants that were called anatomic teardrop-shaped implants. And the idea was that it mimicked a natural breast, which has sort of like less fullness up top and more fullness and roundness on the bottom. So people were going around putting these things in like they were going out of style. Well, what ended up happening in a lot of these patients is that bigger bottomed part of the implant created a bigger bottomed out breast with the stargazing nipples. And I can see it from a mile away when I see that implant. I'm like, oh, someone put that implant in you. I hate it so much.
It's not cute.
It's not cute. The only ones that I find that it works okay in are people that have enough of their own breast tissue to kind of camouflage how ugly the implant is. But if you don't have a lot of breast tissue, it's very apparent that like that's a funky looking implant.
Yeah, and when they move and twist and
and
do
flip.
things, then they create some very odd breast shapes.
Yeah. So we don't really do those anymore.
I never put those in primarily. And to echo your thoughts, I mean, I remember I went to like one of these like sponsored dinners, and they brought like their all-star, like it was like one of the implant companies brought their all-star anatomic implant guy to show the before and after results. And literally I looked at all of them, I was like, none of these look good. I mean, they're
fine.
They're fine. Like they're just fine. But I wasn't like, man, those look great. You know, like, man, those are, I got to do that. Like I was just like, okay, which, there's a lot of stuff in plastic surgery like that. This is why I always say, look at the before and afters of your surgeon. Make sure that they agree with your vision for the operation. Make sure that you're aligned on your vision for beauty, because every plastic surgeon has a different idea of what good looking is. They really do.
Yeah, some people actually really like that look.
They do.
They do. So if they like it, great.
Then go there.
Go for it. Do it.
And that's why these are our opinions. And I really can't emphasize that enough to those of you who are like, I'm thinking about some plastic surgery. Your friend may have gone somewhere, and if you look at them and go like, well, you sure look weird, then don't go to that surgeon,
Or maybe you look at them and like, you look weird, and I really want to look like that.
That's
too.
right.
Fantastic. Go to that
Then
surgeon.
go there. If you're like, God, that is like a crazy look. I want to look like that. Go there.
Great.
But if you look at the results and you go, these look really natural. This is nice. This is where I want to be, and that's what you want. Then that's where you go. It is about the before and afters, and really getting a fair assessment of the work. And reviews, we could do a whole other podcast on like reviews. They're plus minus a lot of times, but you can kind of tell which ones are actually written by patients and which ones are written by their competitors or some hater.
Same.
So you have to be able to discern that yourself.
Yeah, most people can.
Yeah, I think so. At this point, people know that reviews are like with a grain of salt, please. And but yeah, it's the before and afters. It's the office. It's what they've done, and those anatomic breast implants are just not for me. No, thank you.
No, that was not the note I wanted to end on, but here we are. So,
no, I saw it coming. Like there was like a little bit of fire, and like I was like,
oh, something's coming.
I don't know what this is.
See,
should I get under the table? And
now we reversed it. Now I'm the fired up one.
Right.
But that's okay. Yeah. Well, folks, I think that's it. This is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.